I think both regorafenib and nivolumab have a role to play in patients with advanced liver cancer. We are now seeing in the past year and a half that we've had three positive phase 3 studies with lenvatinib, regorafenib, and then cabozantinib. And as far as approvals, as we sit here today, we have sorafenib frontline and regorafenib and nivolumab second line. The challenge for us is to figure out how we're going to sequence these drugs with the given data and when they are approved. At this point, in the second line setting, we've certainly seen patients who get nivolumab and appear to be cured. It's early to say that, but there are patients who many of us have seen have complete responses. It's not common, but when it happens, it's significant. At the same time, though, that has to be balanced against the fact that we have strong phase 3 data currently with regorafenib that improves survival. And certainly we've seen patients who have responses with regorafenib. The response rate with that drug is higher than we see with sorafenib. So, it's a good problem to have several agents to choose from. And I think critical in choosing a choice of therapy is the condition of your patient, specifically in regards to their liver disease and life expectancy, so that we can optimize their chance of getting all active agents. It's very important to keep in mind that in order to get patients the option of second-line therapy, we need to get them the option of frontline therapy. And therefore, it's important for us to transition patients who are getting local regional therapy to systemic treatment at the right time. If patients are not in good shape when they present for frontline treatment, they'll never get the option to get this sequence of treatments that we think is improving overall survival and changing the natural history of advanced HCC. I think after a decade of managing patients with sorafenib in this clinical situation, meaning advanced HCC, I think many doctors are comfortable with the toxicities that we see. Comparing sorafenib and regorafenib, regorafenib does appear to be more potent. We see a higher frequency of hypertension. But as far as hand-foot skin reaction and diarrhea and GI toxicity, I think the management protocols are not that dissimilar from what we've seen with sorafenib. Keep in mind, just because it's an oral drug does not mean we just let patients take it and go away for several weeks. Patients need to be seen early and regularly and educated on being proactive about managing hand-foot skin reaction, using urea-based creams and emollients, being informed on how to manage diarrhea and managing it early with anti-diarrhea agents, and also calling the doctor. It's very important that patients keep in touch with the office should they have problems. Regorafenib is dosed differently than sorafenib. It's dosed 160 milligrams once daily, but 3 weeks on and 1 week off. The dose studied in the resource study was this 160 milligram dose, and I think we should aim at always trying to recapitulate what is done in research studies, and therefore starting at 160 milligrams daily is not inappropriate for someone who is well compensated and good performance status, and then dose adjusting if they have toxicities. I think all of us have some experience with sorafenib that for patients who appear a little more frail, that we do start at a lower dose, but try to dose escalate as soon as possible. We've also seen from the resource study that a patient's benefit from regorafenib is really not related to the dose intensity of prior sorafenib. So even if a patient was on a lower dose of sorafenib for some period of time and then gets regorafenib full dose, we still expect to see a similar benefit as if they were on the full dose of sorafenib prior.